Welcome to this Embracing Complexity webinar, looking at the links between area level socioeconomic deprivation and access to early support. We all know that services can be a bit of a postcode lottery, and we're delighted at Embracing Complexity to have partnered on this project based at the University of Kent's Tizard Centre, exploring the relationship between access to different forms of support and area deprivation. We're joined today by the team behind this research, Suzi Sapiets, Sophie, Laxton and Moriarty, to explain more about their project and their findings. If you have any questions, please do use the Q&A button or the chat on Zoom, or put it on the Facebook comments, and I'll put these to the panel later on. Finally, this webinar is being recorded, so don't worry if the tech fails or if you need to head off a bit early, and we do have live transcription enabled, so you should be able to find a button on Zoom in the chat.
Okay, can everybody see the presentation? All right, brilliant. So hi everyone, thanks for joining us today. My name is Suzi Sapiets and I'm a researcher from the Tizard Centre at the University of Kent. And today I'm joined by research assistants Sophie Laxton and Moriarty, who have been working with me on this project, exploring if where families live influences access to early years support. We received funding from the University of Kent's Summer Vacation Research Competition, and Embracing Complexity were a partner with us on this project.
So the term neurodevelopmental condition is an umbrella term that is used to describe lifelong conditions that can influence the way a person thinks, feels and experiences the world. Many conditions fit into the term neurodevelopmental conditions, and some commonly known neurodevelopmental conditions include autism, ADHD, Down syndrome, dyspraxia and dyslexia. Early years support is a broad term that is used to describe any support that children with neurodevelopmental conditions and their families may receive. This support can be provided by the government, charities, or private services. Early years support can be targeted to the child's and the family's specific needs, and the aim is to help them live a higher quality of life. For example, if a child is having problems with talking or communicating their needs to others, then they may get help from a speech and language therapist who will work with the child and the family to identify problem areas and create a plan that will help the child develop their communication skills and resolve the issues. So, research into early years support has found that it can reduce health and social inequalities, like poorer physical or mental health in people with neurodevelopmental conditions. Research has also found that it can improve children's developmental skills like communication, reduce or prevent challenging behaviour in children with neurodevelopmental conditions. Interventions for school-aged children with neurodevelopmental conditions have been found to improve children's performance in schools. For example, interventions focused around reading and maths can significantly increase reading and maths abilities. And early years support has also been found to benefit parents and carers. It can help educate parents and carers about the child's neurodevelopmental conditions, increasing their awareness of their child's condition and understanding of their child's unique needs. This increased understanding can help reduce parental stress levels and improve communication between the parent, child, and services. And furthermore, improvements made in early years support can have lasting long-term benefits, with children still benefiting from support years after it's ended.
So what influences access to support? So multiple factors have been found to influence access to support for families who've got a child with suspected or diagnosed neurodevelopmental condition. And these can be grouped as factors relating to the family, services, or the wider context. So for example, parental education level is a family level factor which has been found to be associated with access to early years support. With increased parental education level being associated with increased access to early years support. A service level funding can be funding for services. For example, limited funding and resources for services reduces access to early years support for families. And an example of a contextual factor is government legislation. And this is quite closely related to funding. For example, government funding cuts and budget cuts for services has been shown to reduce access to early years support for families. Whereas on the other side, government legislation that stipulates funding for early support has been shown to improve access to early years support.
So our research is focused on exploring the link between where families live and their access to early years support, specifically looking at the relationship between area deprivation and access to early years support. But why explore area deprivation? Findings have shown that families' economic deprivation, such as income poverty and unemployment, predicts lower access to support for children with neurodevelopmental conditions and their families. This research, linking economic deprivation and access to support, has primarily focused on such factors at a family level. For example, researching the link between families' own level of income and access to support. However, research has not explored the relationship between area deprivation in families' local areas and their access to support. So what exactly do we mean by area deprivation? Area deprivation refers to the level of deprivation in small areas in the UK. These small areas are linked to families' postcodes. To measure area deprivation, the UK compares these small areas across 7 deprivation domains. So, for example, as seen on the screen, the employment domain refers to the level of unemployment in a given area. The income domain measures the proportion of the population experiencing deprivation related to low income. And the living environment domain measures the quality of both the indoor and outdoor local environment of that small area. So, based on these comparisons across the 7 deprivation domains, the small areas are categorised into 10 groups, and these groups are called deciles. These deciles are ranked from 1 to 10, decile 1 being the most deprived areas in the UK, and decile 10 being the least deprived areas in the UK. So overall in England alone, there are 32,844 small areas, and of which are placed into these ranks from 1 to 10, depending on their level of deprivation. And as you can see from this map, it provides a bit of a more visual example of this. The darker blue areas, these are the lower deciles and therefore the most deprived areas, whereas the lighter white and green areas shown on the map are the least deprived areas.
Okay, so in the study, we had 2 key research questions. Firstly, we're interested if there is a relationship between area deprivation and access to support for families who have young children with neurodevelopmental conditions, and that was across these 10 deciles. And secondly, we were interested in if there are differences in access to support between families that are living in the most deprived areas compared to families living in other less deprived areas. So for this project, we used data that we collected as part of the Support in the Early Years study, which was part of my PhD research alongside another PhD student called Caitlin Murray. And for this, we did a UK-wide survey of parents who had children aged 0 to 6 years with diagnosed or suspected neurodevelopmental conditions. And the parents completed the survey anonymously between September 2018 and May 2019, either online or via a paper copy. We recruited families through social media and also asked several organisations to distribute to their own networks, such as charities that work with children and families, and services such as specialist schools. And topics in the survey included access to early years support, parental and family wellbeing, and also a range of child and family characteristics For example, like how old the child was, the neurodevelopmental condition, and if it was suspected or diagnosed. And then most relevant to today's presentation is data on where the family live and also their income and economic deprivation.
So to measure and understand the extent families had access to this early years support, we looked at 3 different topics. We looked at the family's access to early interventions, their access to formal support sources, and their level of unmet need for formal support. When measuring intervention access, we wanted to know whether families had access to early interventions or approaches designed to support their child's development or to support them in their role as a caregiver to their child with a neurodevelopmental condition. And examples of these kind of interventions include early intensive behavioural intervention, incredible years, early bird, and therapy or counselling. To measure families' access to such interventions, families were asked to indicate whether yes, they had accessed an intervention of this kind, or no, they had not accessed an intervention of this kind in the last year. And a free text box was also provided for them to just list whatever interventions they had accessed. For access to formal support sources, this refers to the number of formal support sources families had accessed, including key professionals across education, health and social care, health specialists, and other formal support sources for families of children with neurodevelopmental conditions. To measure formal support sources, families were provided with a list of 49 key professionals or other forms of support, and were just asked to indicate whether they had accessed these supports in the last year. The number of support sources they had accessed were counted and totaled to give an indication of how many formal support sources the family had accessed. And on the screen now is just a list of formal support sources to give an idea of a few examples of what this actually means. As you can see, these are across education, health and social care, ranging from educational psychologists, speech and language therapists, sleep practitioners, and other specialist services to meet the child's needs.
Unmet need for formal support refers to the number of formal support sources that families felt they needed to access in the last year but had not accessed. For instance, if a family wanted to have contact with a particular professional but they didn't have access to that professional, this was classed as an unmet need for formal support. For example, if a family felt they needed contact with an educational psychologist in the last year but they did not have contact with an educational psychologist, this would be counted as an unmet need for formal support. To measure unmet needs, families that had selected no, they had not accessed a formal support source, were asked if they had wanted to access them despite not having contact with them. If they answered yes, then this was counted as an unmet need for formal support. To measure area level deprivation, we use the index of multiple deprivation. The data from the index of multiple deprivation was linked to families' postcodes to identify the area level deprivation for where they lived. We used the 2019 version of the index of multiple deprivation to make sure that our data accurately represented area level deprivation. So to recap, the index of multiple deprivation is a government measure that ranks local areas in the UK across 7 deprivation domains to indicate their level of deprivation. The index is scored out of 10, with 1 being the most deprived and 10 being the least deprived. We use the index of multiple deprivation in 2 ways. Firstly, we examine the deprivation deciles to get a measure of the area level deprivation. Families living in deciles 1 would be living in an area with the highest level of area deprivation. By looking at these deciles, we could see if there was a relationship between area level deprivation where families lived and their access to support. We wanted to examine if access to earlier support would be different for families living in areas with different levels of deprivation. We then split the deciles into 2 groups. Higher area level deprivation group, which contains deciles 1 and 2, and lower area level deprivation group, which contained deciles 3 to 10. We did this to explore if there was a difference in access to support between the most deprived areas and less deprived areas.
So to make sure that we were exploring a relationship between area deprivation and access to early years support, and not other factors that are closely related to area deprivation, such as the family's economic deprivation, we also accounted for family economic deprivation in our analysis. And that was just to double check that we were finding an independent relationship between these two variables, area deprivation and access to early years support, rather than family economic deprivation. So how did we measure family economic deprivation? So we measured it in 4 ways with 4 different variables. The first was looking at family income poverty. So to do this, annual income was equivalized, which means it takes into account the number of children and adults that live in the household. And then this was used to identify families who are living in poverty, which is defined as an income below 60% of the UK median equivalized income, or participants who are not living in poverty if they're above that threshold. We also measured subjective poverty by asking participants to indicate their current financial management, which identified participants who were struggling financially or managing financially. We also asked if parents felt that they would be able to raise up to £2,000 for a hypothetical emergency. And this identified families who felt that they could raise the money either easily or involving some sort of sacrifices like reduced spending, or families that would not be able to raise the money, or they would really struggle, such as having to do something drastic, such as selling an important possession. The last thing that we looked at was household employment, and we measured this by asking participants if they and or their partner, if they were living with one, were in either full or part-time employment. And so this identified households that had at least one caregiver in employment, or households that had no caregivers in employment. And what we did is we combined these 4 together to give an overall economic deprivation score for the families. And this ranged from 0, indicating that families experienced no deprivation across these 4 measures, to all the way to 4, indicating that they experienced each one of these. And that would be, you know, living in income poverty, having subjective poverty, so they don't feel like they're managing financially, that they don't think they'd be able to raise money for a hypothetical emergency, and that there's no employment in the household.
So to briefly recap on the information that we've provided so far, our goal was to explore the relationship between area deprivation where families live and their access to early years support. To measure families' access to early years support, we looked at their intervention access, their access to formal support sources, and their level of unmet need for formal support. Area deprivation was examined as ranks, those were for the deciles from 1 to 10, and as 2 comparative groups, the most deprived areas versus the least deprived areas. And finally, we also examined family economic deprivation, as it's a closely related factor, and we wanted to ensure that we were examining an independent relationship between area deprivation and access to early years support.
Okay, so overall, 673 parental caregivers took part in our survey. And on the screen, you can see some of the key characteristics of the participants. So the mean age of the children was 4.8 years, and this ranged from 1 month to 6 years and 11 months. Most of the children were male, and on the screen we've listed the most frequently reported neurodevelopmental conditions, either that were diagnosed or suspected. For example, if a child is on a wait list for an assessment or is currently going through an assessment. And so the most frequent were autism, and that was 77% of the children in the participants. And then 48% for learning disability, 47% developmental delay, 31% social communication disorder, 18% ADHD, and 18% for dyspraxia. And there were also other neurodevelopmental conditions reported less frequently. Most of the caregivers who completed the survey were the child's biological mother, and they had a mean age of 36.5 years. And this map shows the geographical range of participants across the UK for the participants who were able to provide their postcode. And so, as you can see, there was quite a lot of spread across the UK, but mostly from England, and then some participation in Northern Ireland, Wales and Scotland as well. Okay, so this is the area deprivation data for participants in the study. So we're able to link the IMD data for 544 participants, which was 80% of the overall sample. And as you can see from this table in blue, there was range across the decile ranks all the way from 1 to 10. And 1, again, indicates the most deprived areas, and 10 indicates the least deprived areas. And there was between 5 and 10% across these different groups. This other table here shows the distribution when we split the participants into the most deprived areas. So that was rank 1 and 2. So there was 20% of participants there. And then for the other areas, which was the other less deprived areas, and that was between 3 and 10 decile, there was 60% of participants living in those areas. In terms of family economic deprivation, most families experienced some form of economic deprivation that we'd measured. So 58% were living in poverty based on their equivalised income. 18% had no caregiver in the household that were in full or part-time employment. 15% said that they were not managing financially, and 60% said that they would struggle to raise money. Oh, my cat's joining me. And overall, together, combined, families had a mean of 1.5 across these 4 areas, and it ranged all the way from 0, again, where they experienced none of these, up to 4, where they experienced all 4 of these areas of economic deprivation. In terms of access to early years support, we found that less than 1/5 of participants had accessed some form of intervention, either to support the child or the parent. And of those 49 formal support sources that were listed, these were the ones that were accessed by the most. So 84% access to paediatrician, 84% access speech and language therapist, 78% for general practitioner, and then 75% for staff at school, and then 71% for staff at school. And so these sort of cover supports that you would typically expect in terms of like meeting child's needs, or maybe assessing neurodevelopmental conditions or special educational needs in the sort of UK context. In contrast, these were the, of the 49 supports, these were accessed by the least number of participants. So 1% accessed foster carer, 3% endocrinologist, which is a doctor that specialises in hormones, 3% podiatrist, which is a doctor specialised in feet, 5% for support to manage direct payments that was independent from the local authority, and then 5% for independent support advisor. And these appeared to be sort of more specialist supports, and also those that are aimed at like supporting caregivers or maybe the family in general, if we're looking sort of further down the list at sort of like carer centre and local authority housing department. In terms of unmet need, overall 75% had reported at least one area of unmet need across those 27 key professionals from education, health and social care. And so listed here are the professionals that participants reported having as an unmet need in terms of like the highest percentage from those who had not accessed them. So 52% of people who hadn't accessed occupational therapist reported that they wanted to access one, and then 52% for educational psychologist, 52% for staff from the team that assesses special educational needs, and then 43% for behaviour specialist and 40% for paediatrician. And then again, most of these also seem to be related to identifying or supporting children's needs, which was quite similar to the ones that were accessed the most by participants. So overall, most families have not accessed an intervention. Of the 49 formal support sources, parents and families accessed a mean of 14, but this ranged from 0 to 32 supports per family. And then families reported a mean of 3 professionals they had an unmet need for support from, but this ranged for individual families from 0 all the way up to 17 specific supports of unmet need. So Caitlin and Sophie are now going to talk you through our findings regarding the relationship between area deprivation and access to support based on these 3 outcomes.
Yes, so in terms of area deprivation and families' intervention access, our findings show that there was no significant relationship between the area deprivation ranking of the family's local area and whether they accessed early interventions. There was also no significant difference in access to early interventions between families living in the most deprived areas and those living in the least deprived areas. And there was also no relationship between family economic deprivation and early intervention access. So for families in our sample, area deprivation did not seem to impact intervention access. For access to formal support sources, our findings show that the area deprivation rank of families' local area was a significant independent predictor of access to formal support, meaning that families in less deprived areas accessed more formal support. There was a significant difference in access to formal support sources between families living in the most deprived areas compared to those living in the other less deprived areas. And this was meaning that families in the most deprived areas had less access to formal support sources. And there was no relationship for family economic deprivation and access to formal support sources.
For unmet need for formal supports, area deprivation was not a significant predictor of unmet needs for formal support sources. Being in a more deprived area did not increase the number of unmet needs, and there was no significant difference in unmet needs between families living in the most deprived areas and less deprived areas. However, family economic deprivation was a significant independent predictor of unmet needs for formal support. Families with higher economic deprivation reported more unmet needs compared to families with lower economic deprivation.
Okay, so just to recap, in summary, we found that area deprivation was related to access to formal support sources, with families living in less deprived areas accessing more formal support. But area deprivation was not related to intervention access or unmet need for formal support. On the other hand, family economic deprivation was not related to intervention access or formal support sources, but was related to unmet need for formal support. And families with higher economic deprivation, for example, those living in income poverty, subjective poverty, not able to raise money for a hypothetical emergency, and household unemployment, reported increased unmet need for formal support. So what do our findings mean? So firstly, our findings show that there are potential disparities of access to earlier support for families of children with neurodevelopmental conditions in the UK. And this is based both on area deprivation and family economic deprivation. So decreased access to formal support highlights potential variation in services that are available in different locations based on area deprivation, which could be due to like the capacity or availability of services. For example, less support in areas with higher deprivation, for example, where local authorities are underfunded, they might be more likely to reduce service provision due to these cuts. It also highlights limitations of the universally free service system that we have in the UK, as those living in areas of higher deprivation access less support, and families with higher economic deprivation reported higher unmet need for support from health, education and social care. And so this is likely to be related to government funding cuts for services and the implementation of austerity. And our findings also seem to be sort of consistent with those of qualitative studies, such as interviews with families. And because families in the UK have reported that it's difficult to access support across education, health and social care. And some report having to pay for private services, either for diagnosis or support. And this is in part related to the government funding cuts for the public services. So in terms of implications and next steps, clearly there's further action needed to reduce these disparities of access to earlier support based on area and family deprivation. And a number of different things can be done about this. For example, we could look at policies and government investment, both to reduce area deprivation and to reduce family poverty. Or they could reduce the impact of these on access to early years support. For example, we could increase resources for services in areas that we know have high deprivation. And this might address other barriers, such as a lack of collaboration or coordination of services, through enabling them to have more time to collaborate with other services. Addressing shortfalls for the most needed or highest unmet need services could also be important, such as occupational and speech and language therapy. Reducing economic disadvantage for families more broadly is likely to have greater implications rather than just on improving access to early years support, as research has shown that adverse outcomes are related to bad outcomes in families. For example, poorer health outcomes are found in people with neurodevelopmental conditions that are experiencing higher economic disadvantage. So it could also improve things like that. Other areas of actions could be looking at things that services and professionals can do to improve access for families in deprived areas or experiencing economic deprivation. For example, we could look at the catchment areas that services have and think about broadening them so that families living further away can access them. Or providing multiple supports in a single location within the deprived areas, such as like with children's centres or in pre and primary schools, and making sure that a range of professionals and supports can come together as one in those services. So lastly, obviously future research is needed to develop understanding of this. And this could be examining differences dependent on specific support types, for example, education, health and social care, or different therapy professionals. But also we need future research using longitudinal methods that will be able to ascertain if there's a causal relationship between area and family economic deprivation and access to earlier support in the UK context. So that's us. Thanks for listening. We'd like to ask our audience for any questions, comments or reflections. And this can be anything related to our project or reflections on if this matches your own experiences of accessing support. Or also if you have any ideas on what the next step should be, either related to policy, services or future research, then please do share them now. If you'd like to contact us after with any of your questions, comments or reflections, you can email s.sapiets@kent.ac.uk or email Embracing Complexity, but we'll try and get through as many as we can right now. Thanks everyone.
Thank you so much for that. I hope you all found that as interesting as I did. So if you do have any questions, thank you for those who've sent them in so far. Please do use the Facebook comments or Zoom chat or the Q&A button, and we will try and get through them. In terms of questions we've got through already. Sorry, bear with me. There we go. So we had a couple of questions around the age group covered in this study. I know you use an existing data set, but it's 0 to 6 years old, which is potentially quite early for diagnosis, particularly for some conditions. And arguably most diagnosis and support would then happen at school, which might be later on. So I guess the first question would be why you chose that data set in that age group. And secondly, do you think that there is a need for more support targeted in nurseries and other earlier settings?
Yeah, those are brilliant questions. So the reason 0 to 6 years was selected for the original study was because we were primarily interested in this early years period. And so we know that unfortunately a lot of people don't get access to support early on. So we're interested in why do some families get access earlier than others, so that we can improve access for those who don't get access to early years support. The reason we chose to extend it from 0 all the way to 6 was because a lot of children neurodevelopmental conditions may not become apparent until they're in an education setting. I mean, that might not be the case for all, but for some, that's when it first becomes apparent to other people, especially if it's not a family member that recognises that. So it could be like their first contact with teachers and teaching assistants who might be aware of that. But we don't think that the early years is the only important time for people to access support. I mean, I think it's really important that people get support across their whole lifespan, but we want to make sure that people, like children and their families, can get support from the earliest age possible. So that's primarily why we chose that, and that's also why we included children who had suspected neurodevelopmental conditions, and not just those who had managed to get a diagnosis, because of obviously there can be quite long waiting lists once you get to the stage of even requesting an assessment, especially for things like autism, which varies across the UK. And the second question, I believe, was related to improving support in sort of preschools and nurseries. And I think that's because in a lot of sort of specialist schools, they often can have therapy professionals that work within the school, such as massage therapy, occupational therapy, speech and language therapy, so that children can also get those sort of supports while they're at the school, rather than having to access them outside of school time. And I think that it would make sense to have more of those supports available in those settings, especially in things like children's centres, which can be accessed from quite young age. And it's about sort of supporting different areas, and not just things for the child, also for the family as well. So Sophie mentioned earlier things about, helping families learn a bit more about what neurodevelopmental conditions are and how they can best support their children, but also how they can support themselves and their own well-being in the early years as well. So I hope that answers your question, but obviously feel free to get in touch or ask more if you want. And I don't know, Sophie and Caitlin, if you have anything to add, please just jump in at any time. Otherwise, I might just ramble on.
Thank you. Sorry, Sophie and Caitlin, did you have anything to add there, or?
No, I think that Suzi summed that up perfectly, really.
Okay, so we've had a couple of questions which I'll sort of deal with in turn around specific conditions. So firstly, you had a question from Facebook. Autism is at the moment the only condition where services are mandated by the Autism Act 2009. As some of you will know, the new autism strategy actually was published today. How was that taken into account in the study in terms of, I guess, diagnosis, prevalence and access to services, particularly given that economic deprivation itself shouldn't have an impact?
Yeah, no, that's a really good question. And so there was an earlier study that we did which didn't take into account area deprivation, but took into account other factors that might influence access to early years support, such as if the child had received a diagnosis or if they only had a suspected neurodevelopmental condition. At the moment, we haven't examined differences on the basis of what the neurodevelopmental condition label is, but we have examined, if there is a difference on the basis of if they've received a diagnosis or if they're just suspected to have a neurodevelopmental condition. And what we found is that receiving a diagnosis of some kind of neurodevelopmental condition improves or predicts increased access to those early years support. So not intervention access, and it doesn't, and not unmet need, but it does predict how many supports you've accessed with those who've received a diagnosis, accessing more support. So that shows when services do formally identify a need, children do access more support. And the same was found in terms of a statement. So we also measured if the child had received a statutory statement, which could be an education, health and care plan, a statement of special educational needs, or their equivalents across the UK. And we found the same thing, that it predicted access to formal support sources, but not unmet need. And I think actually child diagnosed, the child receiving a diagnosis also predicted intervention access as well. So it wasn't just formal support sources, as I just said. But yeah, we should look into in the future if there's a difference based on the sort of the label, and if the child accesses support, and also accounting for economic deprivation, as these supports are mandated by law, and I think that isn't necessarily specific to a condition, but if there is a need that exists, it needs to be identified for sometimes in order to that to be like to stand up as a legal requirement.
Thank you. And then the a kind of related question to that that's come through on Zoom is around developmental language disorder. which we now know is particularly prevalent, more so than autism.
Yeah.
So why do you think that DLD didn't necessarily come through as one of the main diagnoses in the data set, particularly as it looks like most of these children did have access to speech and language therapists, which is a great thing. But yeah, why do you think that was?
So I think there were parents who did report that their child had a suspected or diagnosed developmental language disorder. I think it wasn't the most frequently reported for a few reasons. Firstly, we provided parents a list of neurodevelopmental conditions that they could select that their child had a suspected or diagnosed, and developmental language disorder I don't believe was recorded on that, although we did include speech, language and communication needs. So that might be why it didn't come through as one of the most frequently reported in this study, because parents would have had to write it in a free text box to then indicate that label had been given. Secondly, I think that it wasn't as frequently reported because it's less well known, and I think there's less awareness both among the general population, but also among professionals, and so people might be, if a child's showing difficulties with communication or a communication delay, people might more suspect autism rather than that, just because they're more aware of autism, and because autism is also related to social and communication differences. But yeah, I think it's similar for dyspraxia. There was less participants who reported that their child had dyspraxia, and that might be because that's also less well known about compared to autism, despite similar prevalence rates. Also, again, it could be related to our recruitment. So we recruited through charities. So people might, some of the charities that helped us were autism specific, such as Ambitious About Autism. So maybe we got more children with autism because of our recruitment methods as well. But yeah, I think future research should focus on lots of different neurodevelopmental conditions, but also probably target those that are less well researched, so that we can see if there's differences in their access to support as well.
Yeah, I agree with Suzi, if I could just jump on this question as well, that that one of the reasons that it could have been less diagnosed is parental awareness of diagnosis, especially if it's your first child with a neurodevelopmental condition. Is a lot of parents don't have the language or the awareness of different conditions that aren't really in the common language. So trying to look around and get that information can be quite hard. So trying to raise awareness for both parents and services about the different conditions is really important.
Thank you. So one last question before I think we'll have to wrap up. Obviously the data set was 2018 to 2019, and the world has changed quite a lot since then. So do you think that the increase do you think that the pandemic, and in particular the increase in waiting times due to COVID, will have a further impact on accessing support for children with neurodevelopmental conditions? And in particular, I'd be interested to know if you think that the inequalities might have changed, might have worsened, improved, etc.
Yeah, no, that's a really good question. And it's a bit tricky to say for certain. I know that there's quite a lot of research going on exploring access to support, not specifically in the early years, and also other impacts of COVID on the lives of people with neurodevelopmental conditions and their families. But there's a lot of the early or preliminary stuff that has come out of surveys with families has shown quite stark differences between families in terms of their access to support. So some families, it seems to have had sort of benefits on their access to support, in terms of like services now being able to like speak to families on the phone or email, rather than them having to, you know, travel, you know, with their child or without their child and find childcare. So in some ways, for some, and maybe even for only some services, access might be improved, and, you know, waiting lists might reduce. However, for other families, they've reported like a reduction or just a complete stop in support. For example, I think right at the start of the first lockdown, there was some families had a great difficulty in their children still getting support, you know, from schools. And that it was like, you know, blanket decisions were made, and, you know, children with neurodevelopmental conditions and their families just weren't considered within that, because we were more focused on, you know, physical vulnerability, for example. So it's tricky to say for certain, but yeah, I think there definitely is there will be differences because of the changes of, you know, the landscape. And I think it is possible that these inequalities based on area and family deprivation might worsen. If we think about it, quite a lot of people have had to, you know, reduce or stop their employment because of COVID, and that might be changing now, but it might not. So things like that might, you know, increase, you know, difficulties accessing support, and that could be to do with, you know, the direct cost of accessing it. For example, if it's you're paying to access a private service and you have a reduction in money, you might have to stop that. But it also could be related to like the indirect costs, like if you have less money, maybe you're not able to pay to get to somewhere, you know, to get a bus or to get a taxi, parking, all those things, or also paying for childcare, paying for like specialist equipment that your child might need in order to access certain things. So I think it's possible it could increase the inequalities, but I know that there's research going on across different ages, and it will be good to sort of see what they're saying when we're thinking about recommendations for improving access, because it will be quite important to take into consideration all the changes in the world since we collected the data.
Absolutely, thank you. So we're coming to the end of our session now. Thank you so much to all of you for coming, and to Suzi, Sophie and Caitlin for such a fascinating discussion. And in particular, sorry for all the technical hitches. We're having some problems with Eventbrite, which we'll look into for next time. My colleagues are hopefully posting some links in the chat and Facebook comments, so you can find out more about Embracing Complexity and our work. Embracing Complexity is currently reliant on grants. The coalition is managed by Autistica, the UK's autism research charity. So if you did want to make a donation, you can find that link in the chat. You can also watch all of Autistica's previous webinars on YouTube. As I mentioned earlier, this webinar will also be available on there very soon. Here at Autistica, we held our annual research festival last week. So all the sessions from that will be on our YouTube channel very soon as well. And if you'd like to hear about other upcoming events, please sign up to the Autistica Network using the link in the chat or Facebook comments. Finally, we would be very grateful if you could complete the short feedback survey that's just gone into the chat. Any pointers? This is only the second survey that we've run, only the second webinar that we've run as Embracing Complexity. So any pointers on what's gone well and how to improve would be incredibly helpful. Thank you again for coming, and I will hopefully see you at the next webinar.